everyone, and welcome back to the Graduate Dentist Podcast, your go-to guide through real-world dentistry and a community amongst grads. My name is Erica Huynh, and in today's episode, we are joined by a very special guest who, if you've been on our Graduate Dentist Discord community, you'll be very familiar with, and that is our endo guru, Dr. Z, aka Zi En Lim. If there's one thing that I love doing on the podcast and always endeavor to do, it is bringing on people at all stages of their career to really show the whole wide spectrum of where you can go in dentistry. The opportunities are endless, and it's all really dependent on you yourself as an individual, because what's right for someone else may not be right for you, and what's right for you may make no sense to anybody else. And I think that's very much the story in Z's case, a lover of all things root canals. In this episode, we dive into Z's journey thus far, going into his third year of practice and finding his passion and love for endodontics as he is currently going through his application process to hopefully specialize. Endo is often so daunting for new grads because the complications and failures can feel so catastrophic. Broken files, perforations, hypochlorite accidents. It's a lot. Z talks us through how we build our confidence in root canals, how to manage our patient expectations, how to communicate with them, and the mindset and attitude we need to adopt in order to get better at any skill set. We dive into how to talk a patient through whether to extract or try saving the tooth, how you run through your risks and complications, giving them informed consent without terrifying them, and how to explain when things don't go the way you plan, like separating a file. All this and so much more in this jam-packed episode. I really didn't think I'd enjoy talking about endo as much as I did in this chat with Z, but I think it really goes to show just how infectious his passion and enthusiasm is. And so I'm really excited for all of you guys to get a taste of it as well. Speaking of enthusiasm, after hearing everyone's incredible feedback after our Melbourne meetup this year, I've taken on board everyone's suggestions and ideas and pieced together our social calendar for the rest of the year. Starting with our Brisbane meetup on June 15th at Bizo Bizo Hotel X in the Valley. One thing I want to preserve and never want to lose with our meetups is that feeling I had for our very first Brisbane meetup last year, and that is the beauty of genuine connection, the warmth, the fun, and the feeling of a community. And so we're keeping all that, the fun, the games, the giveaways and competitions, all that with good food, drinks, company, and a sprinkling of presentations from our favourite speakers and members of our graduate dentist community. We have the wonderful Dr Zi En Lim talking us through protecting yourself, ways of safeguarding your mental well-being and your professional career. I think it was a resounding, unanimous agreement that Annaline's episode with us was the warmest hug, and so now we get that live in person. We've also got our ultimate cheerleader, your biggest hype man, Dr Lingaya Dranavali, giving us a pep talk on finding your why and your passion in dentistry. And so if you've been feeling low and a little bit lost, then this is your dose of motivation from the biggest cheerleader and supporter I can think of. And then for the very first time, thanks to all your suggestions and encouragement, I'll also be giving my very first presentation at one of our graduate dentist meetups. And that is on my favorite topic, communication, which you all hear me talk about all the time and share on the Discord. And I specifically wanted to go into some of the common analogies that I often share and how we can simplify all the crazy complex ideas in dentistry into easily relatable and digestible terms for our patients. It'll be fun and creative and interactive, and I really hope you will have a good giggle and take something valuable away from it. And in case that wasn't enough, we also have a very special panel of our graduate dentist community to answer all your live Q&A questions and share their experiences and their journeys thus far, going through the same things that you will love. We have our podcast fan favorite and composite king, Ben Zhang, the wonderfully fiery and fabulous Julia Haziametova, and our up-and-coming rising star, Dr. Lawrence Fu. I think this is an absolute stellar lineup, and I think we really do continue to raise the bar with each and every one of our meetups. And so be sure to secure your spot and don't miss out. Tickets are $55 each or $35 for students if you DM me. You can find all the details and register via our website at thegraduatedentist.com. For our Sydney siders, we're coming to you on July 13th, so stay tuned and save the date, because if you thought Brisbane sounded epic, just you wait to see what we have in store for Sydney. So with all that hype, let's simmer back down, settle in, and really enjoy this conversation with Z. Welcome to the Graduate Dentist Podcast.
Hello. Good to be here.
For the third time, we're praying to all the endo gods that they allow us to have this conversation because it clearly does not want us to.
No, they're blocking the signals.
They're blocking the signals, but it's looking promising so far. And so for the third time, I'm going to welcome you to the show.
Thank you. Good to be here.
I'm really excited to have this conversation. And I think reason being, like particularly having you on the show in particular, because I guess since starting the Graduate Dentist, my goal has been to really create and nurture this community amongst young dentists, amongst recent grads, create a safe space where we can just share our experiences, share our journeys, and be really just open and upfront and honest about it. And I guess over the last year of recording interviews and chatting with people, I've been able to talk to, I guess, a whole wide range of dentists, from people really experienced, 20, 30 years out, to those that are like 10 years out and teaching, to people right at the very beginning of their career. And I guess you are someone who is still relatively new to the dental industry and yet really kicking goals, someone who I admire and respect a lot. And I'm very grateful to have as part of our graduate dentist community and being such a big active member of it. So thank you for all that you do, and thank you for coming on the show today.
It's a pleasure to be here. And yeah, I think we should be, it's good to share our experiences, and especially experiences as a young dentist for future dentists coming in, because dentistry is hard, and it's important that we share our experiences so other people can feel heard and they feel like they're in a safe space, basically, when we talk about these type of things. Yeah,
absolutely. I think first and foremost, though, your name is Z.
Oh, yes.
I refer to you as Ethan. And I think I don't know whether I've just perpetuated it, but I think a lot of us now on Discord, everyone refers to you as Zethan or the Endo guy. But tell us about it. What is the origin of this name?
So it's my name. My Chinese name is Z, right? Well, actually, okay. So my Chinese name is Zi En, but because a lot of people can't pronounce Zi En, they just call me Z, so Z-I. And then my English name is Ethan, so then Z Ethan, Zethan. There you go.
And it's now become, I guess, your mononym. Is that what we call it? It's just your name.
It has become my name. Like my name is now
your
Zethan.
Name. It is now Zethan. There's no other way around it.
Yeah.
Speaking of that, there, I guess what I was trying to say is that you're obviously quite well known within our graduate community, particularly for the work that you do on Instagram, sharing all your cases, all your endo cases, all those beautiful, PAs, but also being a big part of our Discord community, right? And I think this was something I was very excited about. I think it's almost been like, 4 or 5 months since we launched it. And it was really great because I remember I had this idea of wanting to create just a safe space for our community to just ask questions and share cases and all the things that you're too scared to ask on, Instagram or on Facebook or wherever it may be. And so we created the Discord community. But then I felt like, I'm limited in how much I know. I am still a grad myself. And, there are certain areas that I'm happy to share my experiences in, but other areas that, I myself am still learning a lot of. And so we thought we'd divide the Discord into different channels, one of them obviously being Endo. And when it came to it, I was like, oh, I know just the person to bring on to, I guess, help look after, to moderate that channel. And everyone always says, they're just like, we leave Zethan alone. Like, okay. This guy could eat, sleeps, breathes Endo, but he's got that well looked after. I think everyone just loves everything that you share there.
Yeah, I really do just like Endo, don't I? I just don't talk about Endo all day. Even my nurses get sick of it. I think one of my nurses in our practice, she's been there for years since it first opened, and that's since like 1990 something when the practice first opened. And she said to me, of all the people that I've met so far coming into the practice, I've never met someone so obsessed with root canals in my entire life. So I was like, oh, well, there you go. That's me.
That's me. No, but I think it is unique because I think the stereotype is that most people don't like root canals, right? But to have someone who loves it this as much as you do, but is also so enthusiastic about it and is so passionate and so happy and willing to share, I think is really nice and really special. And I guess I wanted to ask, how does one, fall in love with endo, or how does someone, I guess perhaps going into where you are right now specifically, is how does one who was not born and raised in Darwin end up in Darwin doing endo as much as you
Yes.
do? Tell us the story, Z.
It's a funny story. So I grew up in Adelaide, right, all my
Yeah.
entire life, and then did high school there, and then actually I was going for medicine initially. So medicine was like my thing, and I wanted to do surgery, and not any other type of surgery. Like I wanted to do very refined stuff, specifically like neurosurgery, because I couldn't be bothered, doing the hammering stuff with the orthopedic surgery. I wanted to like just sit there with my hands and just like not move my entire body and just do this, all right, and you like do surgery, like very refined work and working small like spaces, right? Then I realized to become a neurosurgeon, it took, I think I met a neurosurgeon because I was doing like medical, like shadowing and experience and all that. And it took 17 years at least.
17.
17 years. That's what he was.
My
I remember that
goodness.
quote. 17 years to become a neurosurgeon, and it's extremely competitive, long hours, exams after exams, like going through climbing up that ladder all the way to finally become a neurosurgeon. It's a long pathway, and I was like, oh, well, I don't know.
It's a
So
lot to
yeah,
commit to as well
it
as what,
is
like
right.
an
You have to
18-year-old way. Do you really want to do that, right?
exactly right. And I like to be honest, at 18 years old, you do not know what you want to do. Like it changes so much as you grow up, right? So then, and initially, I actually got accepted into Ireland. So I applied for Ireland for medicine, and I got accepted into it. And just a few months before I started, I just kind of reflected, and I was like, no, it's a bit too long to become. It's a bit too long to become like a neurosurgeon. And also, I wasn't really sure about the exact pathway of how, if I became, like if I did my medical degree in Ireland, how would that convert into Australia? And that pathway, is it going to be long? Do I have to sit an additional examinations? It was very complicated. And then my mum suggested, well, the tooth is pretty small. So it was like, have you considered dentistry? And my sister like loved dentistry at the time, and she was really wanted to do dentistry. And at the time, it didn't really cross my mind. Like I just thought, okay, well, we'll give it a go. And so before I started medicine, I transferred into dentistry, and I said to myself, okay, I'll give it a go, see how it is, and then if things don't go down that path, I could always do like at the time as well, at 18, I was like, oh, maybe I can do RMX facts, right? I can do like dentistry first and then medicine after, the pathways are endless. And then in Ireland, we start training endo in second year. So at the end of second year.
Can I ask, why Ireland and why not Australia?
Well, so first of all, I did apply to Australia. I got accepted into JCU and La Trobe University. But at the time, Ireland started first because we start in September. Right, so the start date in Australia would have been February, January, around about that time. So I thought, okay, I started in Ireland and I deferred those two courses in Australia just to see how I'd like dentistry. And I chose Ireland specifically because, well, it had to be either Ireland or UK because they were the only English-speaking dental schools in Europe. And I wanted to, like, I grew up all in Adelaide. I wanted to see what like a big change was. I wanted like a huge change and see what it's like living abroad. And in particular for my university, which is Trinity, their clinical experience they're known for their clinical experience. So they literally take you and they throw you into the deep end, and which is good. It's very good. It can be stressful at times, but that was what I was looking for. Something with a very strong clinical experience, and I decided Ireland. So I was like, okay. And also because Ireland had a joint relationship with Australia. So my degree, let's say I trained in Trinity, it would have been easily convertible to Australia. So that was one of the reasons why I chose Ireland. And then second year hit, And I was like, no, I kind of like it here. so I stayed in Ireland, and then finished my degree then. Yeah. And it kind of fascinates me how like life happened and how I ended up in Ireland as well. And I don't regret any of my decision. Like if I could go back again, I would stay in Ireland for sure. Because as we know, we graduated during COVID era, right? And the reason why I fell in love with endo in the first place is because I did so many endos during the COVID period. And I think that's what literally, I think fate allowed me to fall in love with endos, because all my patients were getting COVID or close contacts, so they didn't come in. And I didn't want to get we had to get clinical experience, right? Otherwise, we don't meet that quota, right? With the struggles of COVID. So what I used to do since third year onwards, all the way up to fifth year, is like whenever my patient had to cancel or anything like that, I would go down to A&E, and if you're writing your name on the board and the patient comes in through A&E, like the triage dentist there said, okay, this tooth is restorable, like, do you want to give it a go and try and save it? Otherwise, we're going to extract the tooth anyways, because it's COVID. We don't have time to do anything but take out teeth. So I'll go down.
You would still see emergency patients. You just couldn't do like elective treatment, right?
Correct.
So people were still coming in with toothaches and everything.
Exactly. But because just to make them more predictable, to get them out of pain predictably, they would just take out teeth, even though it may be restorable, right? Whereas I write my name down and say, hey, if there's any teeth that you think is restorable, that you think I can save, or if they think it's savable, just bring me in and I'll take the patient up. And that's how I got my patient. That's how I got lots of endos done, because I was just bringing up patients from A&E.
Yeah. Oh, that's awesome. Like I almost found a little loophole in the system there where you got to get that clinical experience, but then also discover something that you may not have otherwise necessarily realized you would like as much.
Yeah. And I don't think I would have, it's just because of that COVID era, that allowed me to do those types of treatments, and it just, my life just happened to go into that path,
So at that point, so that's during the COVID times where you realized, okay, you really enjoyed and really wanted to pursue endo. Did you know you wanted to specialize at that point, or you just liked doing endo?
Oh yeah. I remember my first patient in third year, my very first patient was an endo. So I still remember to this day. So in second year, we treat our friends and families in terms of patients, all right? And third year is the first year that we get patients from the hospital. And I thought, coming back to third year, I was like, okay, they're probably going to ease me into it. I'm probably going to do a scale and polish, maybe a filling here and there, all good. And the first patient came in, and it's like a huge hole in his tooth, and it's like, yeah, I'm in pain. I was like, great.
Right? I mean, you said you signed up for Trinity because they threw you in the deep end, right?
Honestly, no, they did. And then my supervisor was like, you know how to do a root canal. You were trained in second year. Start. I was like, oh, okay, sure. And I remember it was a 2-rooted upper premolar. I still remember 2-5, and it took 5 sessions to do that root canal. And I started off with 1, and then I was about to obturate, and I was like, My supervisor came along. He's like, "There's a second one." I was like, "Oh, there's a second canal. Premolars have 2 canals." and I was like, "Oh, okay." And then okay. And then that's another 2 sessions, and then finished it. And I was like, "Oh, that was quite fun actually." And then a couple of weeks later, there was another premolar came in with endo. I was like, "Okay, let's go for it." So I really got thrown into the deep end, and I think after that experience doing root canal, even though it was long, it was stressful, but it was fun for me.
Gosh, bless our patients that we saw during uni. Like you saying that reminds me, I think probably the first endo that I did during uni was a lower molar, and I'm pretty sure it took me 7 sessions, like 7 3-hour sessions to get through. I'm like, the poor patient, but they were so nice about it, just so patient, just happy to sit there as you're like, how many canals is this? When's it ending?
I remember my first molar endo was a lower 6 with 5 root canals, so 3 mesials, 2 distals, and I was like, oh my goodness me. And that took 10 sessions spread over a year, okay? Because she kept on cancelling, because like she had to reschedule, and it took 10 sessions to do that case. And I still remember that case, like my first time seeing like a middle mesial canal, and I was like, oh my God, how am I going to obturate this? I was stressed about it, but it was when I obturated at the end, I was like, that was fun. I'll do it again.
Satisfying. Oh goodness, you're one of those.
Yeah, I was like, this is great.
We're going to dive into that because I remember actually, like, and this is, I guess, something that I'll say here, but I want to circle back to later on. But I remember seeing you post something the other day on Instagram where you're like, where someone asked you, like, why you enjoy endo so much. And you're like, you never know what you're getting when it comes to a tooth, and it's the problem solving that you love. And I find it so funny because I guess it goes to show that, we can all graduate as dentists, but everyone will have a very different interest in terms of what aspect of dentistry they love. Like some people love their composites because they love the artistry of it. Some people love extractions just because it's like you get in, get it out. Like what the goal is just to get the tooth out, in whatever way you can. Whereas for you, like you really resonate with endo because it's that problem solving. It's that box full of surprises where you're like, oh, what's it going to be? How's it going to respond? It's, your little scientific experiment of like, if I try this, will it work or not? So I guess whilst I may or may not necessarily relate in the same way in terms of the excitement and the passion, what I do really enjoy hearing about is your passion describing it and seeing how excited you are about it. It makes me excited and more open to, I guess, appreciating it, right? But let's kind of go on from there. Then you had a really great experience in Dublin doing dentistry. And you said you would stay there. You said you loved Ireland. You were living out your European life, right?
Yeah.
What brought you back to Australia, and why Darwin in particular?
So I stayed there for an additional year to just have some private practice experience, and I loved it because well, first of all, it was Europe, and I could travel around Europe, and it was cheap to fly. Yeah, just weekend, just fly to Paris for 40 euros. So it was great. So every month I was traveling somewhere, and I just loved it. But after a while, okay, first of all, like because I was an international, technically international student, so that means that I could work there for a year because they granted me a visa for 1 year. But then after that 1 year, it was very hard for me to obtain the additional visa to stay in Ireland. So I was kind of reflecting upon like I guess, where I stood in my career. So I was working in 3 practices at that time. So one practice was very much cosmetic, whitening, like more aesthetic composite bonding stuff, more like fixed pros aesthetic stuff. And then one of the practices was I went there once or twice a month just to purely do endos for them. And then one practice was just like a private practice, but it was very busy, like 18 patients, like a lot of emergencies coming in. So that gave me that opportunity to become faster and more efficient with my dentistry, but also do a lot more endos and all that. And towards the end, I was thinking, like, if I reached kind of like a plateau where I wanted to do more endos, but at the same time, like my mum is in Adelaide, and I felt like I wasn't progressing I couldn't progress as much with where I was at in Ireland, and I wanted to do like a little bit more. And I knew eventually, I knew at that point I was going to specialize. Like I knew at the time I fell in love with endo, I am going to specialize, and I was going to do that in Australia, right? So it made sense for me to come back to Australia, just to familiarize myself with, I guess, dentistry in Australia, and then carry on my journey.
There's a lot that comes with leaving university and properly adulting that no one really prepares you for. As a new grad with an income and newfound responsibilities we don't know what to do with, managing finances can be really tough. That's where JS Medical and Dental Finance comes in. Specializing in financing options tailored to medical and dental professionals, JSMDF is a completely independent broker dedicated to finding the best bank and lender for your unique situation. Led by the incredible Jason Savage, who personally came to my rescue and worked his magic and helped me secure a loan before I even started working, JSMDF is committed to supporting you throughout your personal and professional journey in whatever way you need. Whether you're looking to buy a house, a car, a practice, or pay off that year-long CPD course you signed yourself up for, JSMDF offer comprehensive advice tailored to your short and long-term plans. Their goal is to be with you from day one and thoroughly understand your financial needs and provide solutions that best work for you. And so if you're looking for some advice or you simply want to explore your options, get in touch with Jason and his team. A big thank you to JSMDF for helping make being an adult that extra bit easier and for supporting the graduate dentist community.
And in talking about Darwin, so initially, when a few months before I left Ireland, I was kind of already searching for jobs in Australia. I was going through interviews and all that over Zoom, and I wanted to work regional, if not rural, because I knew that there's going to be a lot of endos in those areas. Principal dentist contacted me and we had a chat, and it was like, oh, she's very nice. Then I visited Darwin, and then I took a look at the practice. I visited Darwin, and yeah, I liked it. I really liked it. The food was great. And that was one of the main critical decisions as well. And the practice was lovely. Everybody there was really nice. And there was plenty of endo. So I was like, I decided to choose Darwin. And then, I never regretted my decision. I really love where I am right now. And doing lots of endo. So I'm happy.
That's so good. How has your journey, because I guess you're someone who very early on decided, I love endo, I want to specialize in endo, so I'm going to dedicate my time, effort into mastering this skill set. Perhaps my question is twofold. One, does that mean you don't do other dentistry? Or has your work just become, I guess, more tailored towards wanting to do endo? And then how have you upskilled, I guess, in terms of the complexity of the endo work that you do? Granted, you're not specialized yet. And I guess this, sorry, I'm really, there's a lot to it. I have a lot to ask you. And I guess
I know where you're going with this. Yeah.
But yeah.
So I'm going to say I had a really amazing supervisor when I was in final year. And she's actually, I think she's retired and she's supervising in the Dublin Dental University Hospital. But she said and I had another mentor as well in a hospital. He was a prosthodontist at that time. He still is a prosthodontist. And he said to me, to be a good specialist, you have to be a good general dentist, because you have to understand from the perspective of a general dentist, right? And there's other aspects that you need to, the skills that you need to develop as a general dentist that is important to become a specialist. And one of them is communication, right? Which you're all about, right? Communication.
Yeah. Love it.
And I said to my 5th year supervisor at the time, and she said to me, like, do a couple of years of general dentistry first, because all it takes is one perforation and you're going to hate endo forever. Right? She's just like, you don't know what you love yet, right? Because you've not even worked in private practice or anything. You don't know what it's like. Dental hospital is very different from private practice. You may have to relearn a lot of things. Things are run differently, So she's like, try a little bit first, see what you don't like, see what you like. And if you still like endo, then obviously go for specialty, right? So I was like, okay. So I worked, as I said, 3 private practices in Dublin City. Oh, well, one of them was kind of technically in Wicklow, but yeah, it was mainly in the city center. And I was doing a bit of endo and a bit of, like, as I said, cosmetic stuff and general dentistry. And I really valued that experience because it taught me how to talk, how to communicate, and taught me other skills as well, like restorative, which is still just as important in endo, right? It's not, endo is not just about doing a root canal and then there you go, wash my hands, done, right? You have to put the filling on top of it, right? You have to assess whether the tooth is restorable. Yeah, you have to talk about money. is the tooth worth saving, right? If let's say this tooth is a ginormous hole in it, and then it has 5 ginormous holes, or there's other teeth that has holes in it, is it best or more predictable to do the root canal for this patient? Like it's the treatment planning aspect of it is very much patient centered, right? So thinking the big picture as a general dentist is actually really important when communicating with patients or whether to save this tooth or not. And that was a skill I learned as a general dentist.
Because
right?
otherwise you just focus microscopically on the one
Exactly.
tooth, which you could do the root canal on, but how is that in the whole grand scheme of things?
Exactly.
Right?
How long is that going to last? Is that really truly worth it for the patient to save it, right? And other aspects like fundamentals like taking teeth out, doing fillings, extirpating, those type of things were really important, right, for me, because obviously we don't have the luxury in dental school to do 3 hours on a filling in private practice, right? So there are some, building that speed, that skill to be more efficient with time, working with the nurse, communicating with the nurse, communicating with patients and all that. Those aspects were only skills that I learned as a general dentist, right? And I felt like my skills really did improve. It really did improve working in 3 different practices, actually, because I got to understand how different practices work and how different practices were run. And then when I came to Darwin, right, my skills, I felt, accelerated completely. Like I learned more things within 3 months than I did within a year working in Ireland, because the patients that we see, right, in Darwin, because there's not a lot of specialists coming to Darwin, right, I would have to take on a lot of cases that people would normally refer because we don't have a choice. We have to do it, right? And my principal dentist is a fantastic mentor, and she's like the extraction queen. She honestly is an oral surgeon. Like she can take out any teeth. It's fascinating. So that's how I learned to kind of be more efficient with my time again and learn how to take out teeth. And then she also does a lot of composite buildups, like changing OVD and stuff like that. So I learned how to do that as well. But it gave me still an environment, because there was loads of endos, to still carry on my passion for endo. So I was doing a bit of both, right?
Yeah.
So nowadays I almost do endos every day, which is great. But I still do a lot of general dentistry to this day. And I think that's so important, because it's just to carry on and to maintain those fundamental skills.
Yeah. What percentage of your work do you think now is like general dentistry versus endo, and how's that changed since you started?
I would say it's still 50-50, to be honest.
50-50? Yeah.
I would still say 50-50.
I guess the reason I ask is I wonder whether you have any advice for, and I guess this doesn't have to be specific for just endo, but just in general for perhaps our listeners that have a special interest in a particular area, whether it be doing more endo or doing more wisdom teeth extractions or doing more composite build-ups or whatever it may be, that one interest in something in particular. How do you go about doing more of that one thing? And so I guess for you, and as an example, you went from being in an environment where you may not necessarily have taken on these cases because there were specialists that you could refer to, or there are other people that would do it. Whereas I guess moving to an environment where, well, no one else is going to do it, so you end up taking all of that, I guess, is one thing. But then, do you think there are any other things that you did to allow you to gain more clinical experience? As an example, like, are there other associates that you work with or other people within the community that actually refer work to you? Or how did you build up that, I guess, relationship with people? Or, has it changed the way I guess maybe this we touch on later, but like communicate with patients as to whether you try doing a root canal versus, extracting it? Does that kind of make sense? Like, what things do you think you did that helped build up so that you could do more endo?
Yeah. So the first aspect is that you need to be in an environment where you do have those cases. So, for example, as you mentioned before, if you're in a metropolitan area where there's all the specialists to refer to, then I'll give you an example. So in Dublin, whenever there was a case coming in, And obviously, I was not at the level of the skill that I am today at that time. But when I took on the case, I was like, oh, I'm not sure whether I would take on that case. I would refer, right? But now, because I'm in an environment where like I have so many cases coming in, and it's not like referring to there is a visiting specialist coming to Darwin, but they are pretty fully booked, and it can be quite a bit of time until they get seen, right? Because the specialist is very busy. So because I'm in that environment, I have all these cases where I was like, okay, I'm in a position where I'm able to try on these cases. And also the patients in Darwin are lovely, right? They will say to me, oh yeah, give it a go, So first of all, it's the environment that you're in. You need to be in a position or in an environment where you're in a safe space to be able to explore your passion. And also, for example, if you have a wisdom tooth, you're going to do more wisdom tooth extractions. It would be ideal if you have someone in a practice that also has a lot of experience doing wisdom tooth extractions, because you need someone to come in to save you if you need help, right? So that aspect, you need the volume of patients coming in, right, that require that particular treatment. Second of all is none of my associates in my practice like doing endos.
So, you're like, give them to me.
Yeah, I literally says like, give them to me. I love it.
Yeah.
So they usually give some of their, well, most of their endos to me, and for me to. They would usually like take a PA and it's like, do you want to do it? I was like, yes. And then it's like, book it in. And then that's where I get quite a predominant, most of my endos actually from them, and also from my patients as well. And then also having a close relationship with a mentor. It doesn't need to be someone in the practice with you, because, well, no one in my practice likes doing endo. So most of my, I guess, advice that I get is actually from endodontists from Instagram. So I'll just send them a quick message. It's like, hey, help. Please advise. What should I do? How do I obturate? How do I shape this? Like, what should I do? And all that. And I've been doing this for quite a number of years since I started, and just bouncing of ideas with them, and just showing them cases. What should I do? And also looking at their cases, because there could be a case that they're doing that is very similar to mine. And then I read their caption, I read how they're doing, I read the comments, and then see how they're, handling the case. And that will be my additional learning. I was like, okay, I'll try that on my patients. So that's how I essentially got. I think I would say that's my advice. So first of all, get the environment, get the volume of patients, and ideally get a mentor, and that will help you explore that passion a little bit more.
I often say on the podcast that the more I do, the more I realize just how little I know, and how dentistry is just one of those careers where you never stop learning. But let's be real, getting the right training can be expensive, time consuming, and sometimes just straight up overwhelming. That's where Ripe Global comes in. Founded by Dr. Lincoln Harris, Ripe Global is completely changing the way that we learn. They offer immersive, hands-on training that actually fits into your life. Whether it's through improving your preps, getting faster with composites, or tackling more complex cases, you'll be learning from some of the best clinicians in the world without having to take time off work or spend thousands on travel. And so if you're serious about upskilling and boosting your confidence in the clinic, check out Ripe Global today. Hit the link in our show notes and let's start learning smarter, not harder. I think perhaps if we think back to what it's like being a new grad, where I think, like, for me, I didn't really have much endo experience, nowhere near the amount that you did when you were exploring all those COVID patients and giving them the option of doing endo for teeth, otherwise that would be extracted. But I didn't graduate feeling very comfortable in actually, no, let me take that back. I think if I bring myself back to my first year, I remember thinking, oh, yes, I can do this. And I had a tooth, like a molar, lower molar. I'm like, yeah, I've done this once in dental school, and took me, 7 sessions to do. Ended up perforating it, and it doesn't feel good as a grad doing that. And I think that's because it's like you haven't done enough to really understand what you are doing, or be able to case select and know what is within your capability and what may be more challenging. You just see a tooth, and you're like, okay, it's a tooth. It needs a root canal, sure. And I don't think you necessarily know what you're looking at yet and why it may be difficult or whatever it may be. And I remember after perforating that first tooth, it was just like, okay. I think a bit of like a wake up call of being, you know what, you don't have to tackle the crazy cases straight away. You don't have to be finding MB2. You know, we're just going to take it back to basics and we're just going to do single canals. And I think for a good few months, just to regain that confidence, I only did like anterior endos, just single canals, just slam dunk cases where you're like, okay, I understand the process. And then after that, I was like, okay, let's try doing some premolars. And then you get more comfortable doing premolars. I'm like, okay, I don't hate endo that much, right? And then it's like, okay, let's try doing some lower molars. And then, okay, let's try tackling some upper molars. But I think that's the experience of, regardless, we're talking about this, I guess, in the context of endo, but I guess I want our listeners to also keep in mind that I think our discussion isn't exclusively just about endo. It's the same regardless of whatever skill set it is that you want to learn, right? But it's slowly challenging yourself a little bit more each time. And one thing that I know you openly share about as well, and that's something we're going to dive into, is that, you know, you get better by doing these trickier cases, but it's being able to manage the complications. And I think there's that fear as a grad of, I think endo in particular is so scary and daunting because there's so many things that can go wrong. It's like, what happens if I, snap a file? What happens if I perforate? Or what happens if there's a hypochlorite, accident, or extrude calcium hydroxide, or this happens, everything. It's just like, it's the worst possible thing where you just catastrophize everything. But I remember talking to Dr. Mehdi Rahimi as a student, and, one thing that he said that really stuck with me was, if you haven't perforated a tooth, it's just because you haven't done enough endo. And that's the same with any procedure. If you haven't made this mistake, you just haven't done it enough. But by making that mistake and learning from it, and learning more so how to manage it, I think is how you truly upskill. And I guess, correct me if I'm wrong, it's being a good, I guess, dentist or being good at endo isn't avoiding file separations or avoiding perforations, because those things happen inevitably, but it's how you manage and correct and overcome those cases. What was your experience with, I guess, that?
That was another thing I wanted to touch on from before, like, for someone who wanted to specialize or have a special interest in something, you have to be prepared to make mistakes, right? Because we are all human and we all make mistakes, but we have, instead of, it's to be honest, it's a small mindset thing. So if you make a mistake and then you're like, oh no, I'm a terrible dentist and all that, right? Which we all experience that kind of, and I'm going to tell you one of my experience as well, that feeling, right?
Yes.
But it's what we do afterwards, right? So if you do that and you don't learn from the experience, and then you're like, okay, I'm never touching endo again, right? Then you're not going to progress more. So you almost have to be comfortable making those mistakes and learning from it, and then being brave enough to try again, right? Which is what you did. Like you took a step back. You started doing more like single canal, kind of ease it into it, and then get back into endo again, right? And it's all about making that mistakes and learning from it, that you will really progress in your journey. And I think the reason why I've progressed so much is because I've made so many errors. So, right? Like I think I've nearly made every mishap in endo so far, right? And I'll tell you my first one, all right? I remember this one. So the first one is a perforation, and it was a lower premolar, and I was like, I could tell it was a single canal lower premolar, and I was like, easy, no problem. Like, look at the access; it's just blinking at me. It's great. I took my burr, sunk it right down, boom, all the way down. I was like, great, I'm in the canal. I can finish this in a single session, right? Yeah. Went inside, and I was like, oh, it's a bit calcified then. That, like, it looks a bit calcified. Okay, let me just open up with like SX, and I just open up. And I said, okay, I'm going to irrigate now, and then blood came out, right? And then I was like, this tooth is non-vital. Why is it blood? Maybe it's like those special ones where it's like there's a periodic radiolucency, but it's like inflamed pulp tissue. And the patient was not in pain, by the way. He was perfectly comfortable and all that. And all of a sudden he raised his hands like, I taste something sour. And I was like, strange. Maybe my rubber dam is leaking. So at the time, I changed literally my isolation to like 3 times. Like did like 654, and then switched it up to single tooth isolation, then switched it up to 654 again with liquid down. I was like, I kept on irrigating. It's like, I still taste something sour. then I was like, okay, let me just dry everything, like rinse with saline, like dry everything. And I looked down and I just see some like this red dot where my SX was, and it was like pulsating a little bit. Well, not really pulse, like just a little bit there. I was like, let me just stick an apex locator in there and just went beep. I was like,
Oh,
and
yeah.
the worst thing is I took a PA, right?
Yeah.
And you can't see the perforation because I perforated lingually, right? Because I kept on telling myself the lower premolar, it leans, like lower premolars lean slightly lingually. So I said, okay, you must stick your burr more lingually. You must stick your burr more. Don't perforate buccally. Everybody perforates buccally, right? Don't perforate buccally. And then I perforated lingually.
Lingually.
And I still didn't know I perforated it. I took an SX and I opened the perforation up again, right? So that was like, shit. Or I was like, oh no, this is not great. And usually like with perforation, they will feel it, right?
Exactly,
And
right?
he
Yeah.
did not feel it anything. So that's why I didn't even realize
Wow.
I perforated. So that tooth had to be extracted. And I didn't sleep for 2 nights. I was like, do I really like endo? Am I like, do I deserve to be a dentist? Like I can't even find a single canal lower premolar.
Yeah.
And then but then, after 2 nights, I was like, okay, you know what? Yeah, I learned from my mistakes, right? I shouldn't overthink it. I should I'm going to give it a go again. And that's like, you move on from that experience, and then, you take on more cases again, and you slowly build your way up, right? And yeah, that's, and in another case as well, it was like, I couldn't tell you how many times I've separated a file, right? And
Yeah.
ledged, blocked, you name it, done all of it. And
Mhm.
it's all about learning from the experience, right? What could I have done differently? What did I do wrong the first time round? And just managing those cases, right?
Yeah. I
Yeah.
think perhaps the first mindset shift, and that's what you were kind of alluding to, and perhaps it's even just the terminology that we use, but seeing them as complications as opposed to mistakes. And I think maybe it's because, I don't know, this is how I think I felt or feel personally about endo, is endo complications feel so much more dramatic.
Yeah, that's true.
Melodramatic, right? But it's just like, oh my god, like a hypochlorite accident, or like, extrusion, or whatever it may be, separating a file. I don't know whether it's from uni, but they feel like really high risk, adverse reactions or effects that can happen as a result of these complications. But you have those complications in any procedure that you do. Let's just take like a filling as an example. You can get an overhang, right? You can have an open contact. You can have a pulpal exposure. It's like, you have that in all of those other procedures as well. It's just everything that we do, there are those risks and there's other complications that can arise as a result of it. But I think the true sign of someone who knows what they're doing, like a true sign of a good clinician, is the ability to foresee and manage and overcome those challenges and those complications. And I think, I don't know, I think being in going into our third year now, I think that's what I realized when I look at cases. There's still so much more to learn, but I think there's context when we start talking to like our new grads now, or like younger dentists, and you realize, oh wow, I see so much more than when I was like them in my first year. It's just like, oh no, we don't want to do this, because if I do this, I know from experience I'm going to create a ledge, or I know from experience this is what's going to happen. I know from experience that's what will happen, and that will make my life more difficult. As a result, we're going to do that to avoid it, or whatever it is. So I think the more you do, and that mindset shift of realizing, if you do everything perfectly, it's not really a sign of skill, it's just luck, right? Because true skill comes from being able to foresee and manage and overcome all those challenges. Hey.
Yeah, and true skill is also about practice, right? Not only on practice doing endos, but practice at communicating. So with time, you get better at communicating risks to patients,
100%.
right? So endo is not 100%, nothing is 100% success rate, right? So if you can communicate to the patient and understand that there are risks in this particular case, like for example, of a calcified canal, there are risks that it could be blocked, file separations, and all that. You've already anticipating the patient, like on those risks, and they understand that before going in, right? Because endo is a procedure that has risks. So if you give yourself that communication platform, or that the environment where you've already anticipated the patient and the patient understands this, then if, let's say, it does happen, it's a lot easier to manage, right? Because you've already primed the risks to the patient. So I think that aspect of it, like communication, is probably more important than
Absolutely.
doing the endo itself. Right. There was I did a course, the Advanced Contemporary, I think it's called Advanced Contemporary Endo 2-day workshop in Sydney. And Dr. Mark Johnson was one of the lecturers there. And that was life-changing. Like the way because he draws out everything. So he like draws out the tooth, and then he, like, if there's a post inside, he would draw that. And the way he communicates all that risks to the patients, like, oh, got to remove the post, you draw this is the risk, what can happen, like, post-op pain, blah, 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 blah. And then talk about money, like costs and all that, is so clear and so easy to understand that for me, if I was a patient and something happens, I was like, oh yeah, it's fine. You already told me all these risks. Yeah, so I think that aspect was really quite life-changing for me because, as you said, endo is a type of procedure where if something does happen, it is a bit scary because the outcome is potentially the loss of a tooth, right? So if you communicate those with, that was really helpful. And I remember that truly was quite inspiring for me. And I think that was the most important thing I took from that session, was how to communicate those risks and being comfortable communicating, right? So I think if sometimes a fresh graduate, because they're afraid of making those mistakes, they'll go in of it like a single canal and Uppenshizer, like that, and they would say, oh, the risks are file separation, and they would name all the things and all that. But I think with time, you've gained experience, right, doing the endos and both communicating, it won't sound as scary anymore, right? So I remember, like, as simple as something like file separation, right? I remember I'll tell you another story. So my I remember my first file separation of this lower molar, and I literally, my heart sank, right? I could visually see my face sink, right? And my nurse was like tapping my shoulder. He's like, are you okay? Because I pulled out the file, I was like this.
Oh, goodness.
And then I was like, I was so like, oh, I'm so sorry. The file was broken inside of your tooth. I was panicking, and then the patient started to panic and all that. And then it's like, oh, I can give you some antibiotics. And it was just because I was panicking, the patient was also panicking as well. But nowadays, if I separate a file, my heart still sinks, but I keep more of like a composure. But explaining to a patient, it's not like the way I explained to a patient would not be the same as what I did last time. Like I'll be a little bit more calm on an inside when I explain to a patient rather than how I did last time, right? And I think, I don't want to say the more you separate files, the easier it gets, but I think the more you, I guess, the more you're comfortable making mistakes, the more you communicate these experiences, or the way you communicate with patients, will make endo slightly more easier than you think. So, I think that's the main point I wanted to make.
Yeah. Well, I wanted to dive into that communication with you because I think it is something that there is such delicacy to it, in that you want to be able to communicate. It's like there's a spectrum, right? And I think as grads, we struggle with finding that balance because on one hand, it's like you tell a patient they need a root canal and then you don't go through any risks and complications, and then they expect that it's going to be this magic pill that they swallow and then, hey, the tooth's fine, it's going to last forever. And if you haven't gone through all those risks and complications, then you haven't preempted it, you haven't set those expectations, and if something goes wrong, then they're going to blame you for it. So that's on one extreme. But then the other extreme is the new grad that is terrified of all of these things happening. And so they say it to the patient to feel like I've covered all my bases and I've put all the blame of anything that could possibly go wrong onto the patient and off yourself. But then in doing so, you overwhelm the patient and you freak them out. And they're like, I really don't want to get this endo done because it does not sound like a good idea, right? And so do you have almost, I think what's important, like what's valuable as grads is almost having a bit of like a script or a bit of like a checklist of what things you cover. And then over time, you find your way of saying it that's comfortable with you, that suits your personality, and you're confident in it, where it's delivered in a way that, you know, it's a good balance of you've done your due diligence, but you're also not freaking them out. And I think what you were alluding to as well is with experience, not that you become, I guess, desensitized or emotionally detached, but things freak you out less and you take that emotion away from it, because at the end of the day, I don't think patients know what is going on. They don't see what is going on. We might be watching it bleed, but they don't know that it is bleeding, right? And so how you react really influences how they respond to it.
That's another aspect of it that you touched on. Yeah. So
Mm.
with the communication part of it, which is
Mm.
try not to panic
Yeah.
when that happens, and try not to make the patient panic. So I'll give you an example. Like I think so whenever I separate a file, right? I never say like file breaks or like, yeah, that because that's scary, right? And the way well, this might be a little bit controversial, but I learned this from an American endodontist that I watched on Instagram. He says either like separated instruments, that's one of them, but sometimes that can be a bit like scary as well. Like separated, it's a bit
Yeah.
scary. So I normally say like, sometimes when you instrument a canal, the file is left behind. Right? Which is a bit funny because it sounds like you did it on purpose, right?
Yeah.
It's like, I definitely delivered. It was all part of my plan to separate
Intentionally
the file.
left behind.
Yeah.
Yeah.
So, but normally this is exactly how I would say it. It's like, yeah, sometimes the canals are quite skinny, and it puts a lot of force on the file. So sometimes the file gets left behind inside the canal. Now, it doesn't necessarily change the prognosis of the tooth, but because after all, canals are little tubes inside your tooth, and then it's essentially a root canal. What we do is we fill those canals with root canal filling, so that separated file will just be incorporated as part of the filling, and then done. That's pretty much it. So which is true, right? Which is correct. So we already know that separated file does not change the outcome of root canal treatment. Right. So, and I say, if you have any problems, then we can deal with that at a later time. But majority of the cases, they do not cause any problems. And then the patient's like, cool. And then that's it, done. Right. And then they move on. So it's about understanding the concept itself, because a lot of people actually think that you do have to remove every single file, right, inside of the tooth, which is actually incorrect. Right. You don't have to remove files all the time. Right? In fact, it does more damage to the tooth to remove the file. And if you can bypass it, or the canal is clean, or well, as clean as possible, right? Then that separated file inside the canal is not going to cause any problems. So having that understanding on a theoretical basis, and also translating that to your communication, is going to make the experience a lot less scary, right? If you need help. And it's the same goes for me, right? I DM endodontists all the time if I need help and anything, and that's what they're there for. That's what a specialist is there for. They're meant to be a leader in the field of endodontics, and that's who you turn to if you need any help. So I think, you don't have to take on every case, and if you feel more comfortable referring, always refer. But tackling that aspect, if you want to get better, you have to be willing to make mistakes and communicating and learning from those mistakes.
You all know that if there's one thing I am super passionate about and always advocate for on our podcast, it is our mental well-being as dentists. There's no denying that our profession can demand so much from us, and it can drain us physically, emotionally, socially, and mentally. And some days it can all just feel a little too much. This is where our friends at Dental Practitioner Support come in. Whether you're new to dentistry or have been practicing for years, Dental Practitioner Support is here to offer guidance, reassurance, and a safe space to talk about whatever it may be that's weighing heavy on your heart. They provide 24-hour services that are completely confidential and independent, so you know that you will always have someone to turn to. Whatever your scenario may be, Dental Practitioner Support is just one call away. And And so, in case you ever need it, save the number 1-800-377-700 or visit their website at dpsupport.org.au. Remember, as we say time and time again on the podcast, you are never alone, and we really are all in it together. Let's play out a few scenarios. And I think there's two very critical conversations when it comes to doing endo that is really important to understand and have your head wrapped around. And if you kind of have these solidified in your head, I think it makes things a bit easier when you go into these cases. But number one is, let's describe the classic situation of, it's a Saturday, you're working, and a patient's come in with a toothache, huge hole in it, and you have to have the conversation of, do we save it or do we bin it? What would your conversation with the patient look like?
So the first thing, obviously with everything, is the tooth restorable, right? So if you can save the tooth, then okay, then you can have that discussion. If you can't save the tooth, like the tooth is a goner, then obviously take the tooth out, right? So let's hypothetically, the tooth is restorable.
Assume,
right? For me, I'm a little bit biased because I want to do I love saving teeth. So I have that, like, I will always try to convince, if I feel like I can save the tooth and I think the tooth has good prognosis during a root canal, I will present that, right? So the way I would say is, okay, you have two options, right? Option one is you can give the tooth to the tooth fairy. Right? I got that quote from my principal dentist. I love it.
That's so cute.
That, right? Yeah, it's just like option one, you give the tooth to the tooth fairy, but then you're missing a tooth there forever, and then you have to find replacement options, right? Option two is we do a root canal treatment, and that basically means that we're cleaning and shaping the root canal space. We fill the root canal and we put a filling over the top. All right. So think of me as a glorified plumber. I'm doing the plumbing for your root canals, and then after root canal, we do place a filling over the top, but you do need a crown on top of the tooth because after a root canal is done, the tooth is more likely to fracture, and that's why when we place a crown on top of the tooth, it acts as a helmet to maintain the structural durability of the tooth so that it can last for a very, very long time. Okay, so that's literally what I say. And then I said to the patient, if you do take the tooth out, or give the tooth to the tooth fairy, right? You have the option of doing nothing, right? But then you have to accept there's a gap there. Or you can look at replacement options like having a plate, or you could go for something like a bridge or an implant, and that has an additional cost as well to replace it. Or you can try to save the tooth, right? And if I think the tooth is like very, very, very restorable, like plenty of tooth there for me to work with, I'll usually say like a root canal, especially with this tooth, if we put a root canal and put a crown on top of it, you can have the tooth for years, for a very long time. And the great thing, this is how I convince patients to do root canals. and then I say to them, well, if you do a root canal option, right, nothing lasts forever in dentistry. So let's say you put an implant there that lasts for maybe 20 years, but then if your implant fails, you've got no more options left. You're left with just a plate. Whereas if you do a root canal, you can have that tooth for a very long time, right? And if that fails, you always have an option, a backup option of an implant. So, and then, and if the patient's quite young, I would say you're quite young. So, if it was my tooth, I would recommend having a root canal done, like so that you can save the tooth as long as possible, and you still have some backup options. But ultimately, the decision is yours, right? And then they will think about it. And let's say they are in pain, right? I'll give them a third option. I would say, okay, if sometimes you're in pain, it's very difficult to make a decision because especially if you're not in pain, there's like, just get it out, right? Just rip it out, and you don't want them to make that, like sometimes that mistake. So I would say, and if you need some time to think about it, I can buy you some time by just putting some medicine inside of the tooth, put a temporary filling in it, get you out of pain first. And then when you come back, you have to think about it. Then you can tell me what options you want to go for. And I'll give you a quote on the two options, and then meditate on it, sleep on it, and you come back to me when you're out of pain. And then if they say, no, I just want to do the root canal straight away, then we start it straight away. If they say, yeah, actually just get me out of pain, let me have a think about it, and they'll just do that. Or they say, just yank it out and let's take it out, so that's essentially how usually how I explain to the patient.
I think that's very similar to how I communicate with my patients as well. And I think the bit that I wanted to hone in on a few little points or comments that you made that I think is so important when it comes to patient education. Number one being, okay, yes, you can remove the tooth, but it's gone forever and you have to accept that there will be a space there. And what I think patients don't realize, and whenever I talk to patients about this, they'll be like, oh, no one's ever mentioned that to me before, is that when you remove a tooth, things don't just stay that way. Like, your other teeth are going to suffer. They're going to collapse into that space. The top tooth will no longer have its dancing partner. So it'll continue going, upwards or downwards, whatever it may be. It opens up this whole can of worms of other issues. And the rest of your teeth suffer because of the consequence of losing one tooth, right? So I think that's number one. And then number two, I really like how you say, yeah, it's not going to last you forever, but you're quite young. And even if it lasts you another 5 years, another 10 years, another 15 years, you always have the option of plan B down the future in 10, 15 years time, as opposed to you do that right now and that fails, then what next, right? And I think that really puts things into perspective, because that's what patients don't necessarily always realize and understand, is that, oh, we understand the restorative life cycle and we understand what can happen next, but they're just like, just take out the tooth and that's it, right? And they don't realize that, there are consequences to every decision that you make. So I think that's really important to be able to explain and communicate that to the patient. One term that I really liked, that I don't know, for whatever reason I stumbled upon it a few months ago and I've been using it, is either one, yeah, you bin the tooth, you take it out, or two, we try saving the tooth. And I describe a root canal as like fossilizing the tooth, where it's like you get to keep the tooth. It's essentially like the tooth is still there, but it's no longer alive. We're essentially just fossilizing it, but still your own natural tooth. And then you can go into the nitty gritty of what you do like afterwards. But just for the sake of simplification of what we do, I find that a really nice term to use.
Yeah, and that plumber analogy was, I learned that from Dr. Mark Johnson, because he's a specialist, right? He doesn't restore the crown, like the crown after the root canal. So he would say, "I'm the plumber." The plumber doesn't quote for the builder. So the builder is the general dentist putting the crown on top of it. So I thought that was brilliant.
That's
right?
Such a beautiful analogy, comes together.
Yeah, right. It's like, I'm just the glorified plumber of your root canal. I place a filling over the top, but then you have to go back to your dentist, the builder, who will put the crown on top of it. So I'm going to take that for the rest of my life. Yeah, I'm going to run with it. And that line when I said like, "Oh, you're very young," that line works great on elderly patients. Because I was like, "Oh, you're very young. You want to save the tooth." It's like, "Oh, stop! I'm only 70." So it's like that line works great on them. And usually with more elderly patients, they don't. I mean, understandably, they're on a lot of medical history. They might be on bisphosphonates. They don't want to no one wants to get their tooth taken out, to be honest. Most people want to keep their teeth. So I think that line and that concept of trying to be almost root canal is almost being conservative, right? Because you compare it to an implant, which is a surgery, right? And in that concept of surgery and having that time to osteointegrate and all that, and then having a gap there for a prolonged period of time, can sometimes be a bit of a turn off for some patients. So I think if you frame root canal as being actually something that's quite gentle, I think that's also another way of reducing the fear of having root canals, right? And also for me, because if you numb the patient up, right, and usually most of my endos are single visits, so I usually tell the patient, just think of it as a really long filling. Like just a really long filling. And then that's and usually that works out well. Yeah.
I want to come back to your single visit endo. There's so much I want to ask you still, but continuing our communication piece, I guess like risks and complications. I think, and this might be different for me compared to for you, because I don't do endo to as high of a level or as complicated as you do, but I set the bar very low. And I'll always say, I think I learned this from one of my friends actually in my first year. And I'm like, that's a good way to put it, to really set the bar low. But I always say that doing a root canal is our last ditch effort to save a compromised tooth, because the alternative, if this doesn't work, it's to take out the tooth. So we're going to do everything that we can in order to save it. But it is difficult. So I always say that it's difficult, but that, and I don't usually say that. I think for me, there's a distinction. Why I say these are two separate conversations is because there's, I guess, the treatment planning conversation of, do you want to try saving it or do you want to extract it? And I kind of want to separate the risks and complications from that decision making. But then once we've decided, okay, we understand it, we want to try saving it, then when we actually decide to do it, then it's like, okay, this may, or depending on the complexity of it, is that it's the last ditch effort to save a compromised tooth. We're working in very tiny microscopic areas, right? And so whilst we do our best to clean it, there are some risks and complications involved. And then you kind of go through them, you rattle off it. We might find that the canal chambers, we're expecting this many, but sometimes they can be calcified. We may not find all of them. You might encounter a defect. If it's overly complicated, I may need to refer you off to a specialist. That's kind of, I guess, my risk and complication spiel.
Yeah.
How would you frame it?
Well, so it depends on the case. So first of all, the most common, I always start with the most common complication, which is post-op pain, right? So like patients just want to be out of pain and can use the tooth, right? So the most important part I always talk about is, so especially after I address the tooth, or let's say if I obturate a tooth, I would say, okay, some things that you might occur after today is that you might experience some post-op pain. And that's because we've gone inside your tooth and your bacteria were having a party inside of your root canals, and I've gone in there and kind of did a party pooper and just disturbed the party. So sometimes your body has a reaction to that. All right.
Yeah.
Usually it lasts for a couple of days, up to a week, take some Nurofen or Panadol, and that usually wears away. Right. And that's what happens. And then patient's like, cool. Right. And then if the second aspect of it is, if it depends, it will be a case-to-case basis. So for example, if I have an upper central incisor that's a humongous canal, I won't say foul fracture is one of the risks, because the chances of that happening is
very low.
Because it's extremely low. That's not going to happen. So I will usually just say the post-op pain complication, right? If like other aspect, like I would say, sometimes if it's extrusion, something like that. At this point, like if I wouldn't say that, like, to be honest, if you extrude some material outside the canal, sometimes depending on how much you extrude, right? That might not affect the prognosis of the tooth either, but that will cause post-op pain. So I've already addressed that aspect in that post-op pain. I might just reword it as in, okay, because there was a bit of excess medicament or excess medicine inside the canal when we're trying to clean it up, so your body might have a reaction to that, but eventually it will resorb away or will heal, right? Then let's say we encounter a curved canal, calcified canal, those type of cases, that's when I say, okay, your tooth is a very funny shaped tooth, it's very curvy, it's very skinny, and that can put a lot of stress on the valves, and sometimes the valves can get left behind, yada, yada, yada. And that's when I'll introduce those cases, right? Those complication risks. If let's say there's a case coming in as severely curved or severely calcified, that's when I talk about the risk of file separation, or like the risk of leaving a piece of the file behind, right? And usually those cases usually covers it as well. And then if let's say we encounter any anatomical defects or any communications, then I'll talk to them about it, right? Unless that was already there before, right? Or like, for example, in the case that I'm tackling on, it was, that was the risks that I would have probably told them before I started the root canal, because it was already there in the first place. So that's pretty much it, right? So the other risks don't occur often if you do everything right? Yeah. So I feel like personally, if you tell all these risks to the patient, they might actually just choose to take the tooth out,
because it sounds too scary, too complicated,
too scary, right? And then so I feel like it's how you word it as well. So the way I communicate when I'm talking to patients about the options is, I only select like the risks that are most likely to occur in that aspect, right? And yourself, like if you're going in and you can't find the canal, like I think part of the experience is also knowing when to stop, right? And then it's like, okay, this is weird. Like, why am I not at the canal yet? That kind of aspect of it. It's that point to stop and then to kind of reevaluate.
But
What
that
you're
comes
doing.
with experience. Otherwise, you end up,
Yeah.
as you, when in that very first story that you shared, without experience, you end up, continuing to expand your perforation, right? But because you don't know what you're looking for, right?
I mean, and there is a balance. So in that first situation, my first perforation, right, I was going too fast, guns blazing, just sinking, boom, right, all the way. So that aspect was me not identifying like my mistake in the first place, right? So from that experience, I always take a bit of time to angle my burr before I go into the access. Like that was that learning aspect. And then let's say I can't find the canal, those kind of situations, like I'm troughing and I can't find the canal. I can't remember who was the endodontist. I think it was do you know Dr. Ivana Timmerman? Yes, that's right. Yeah, I remember she did a post and she did I have a rule where it's 15 or 20 minutes. If I can't do something, I'll change it up, or I'll take something, or I take an X-ray mid-treatment. That was something that resonated with me. So after 15 minutes, I'm like, something is going wrong here. So I'll just stop and I'll reevaluate, see where I'm going. Am I in the right spot? Maybe take a mid-treatment X-ray or mid-treatment CBCT, and then carry it forward or try something different. And it's actually very similar to taking teeth out, right? If you're going in digging and it's not coming out, change something. Right? So try a different technique. So it's the same thing, right?
Same principle, same philosophies. Hey, yeah. You mentioned before that your preference is to do single visit endos. Tell me a bit about that. Has that always been the case, or what's the philosophy behind that? I don't do single visits, so I'm very interested in how you do it.
Yeah. So the reason why, first of all, not all my endos are single visits. And I always try to do single visits, but sometimes I'm not capable of doing it in single visit. The reason for me is the most likely form of failure for endodontically treated tooth is not because the endo fails, right? It's because the tooth fractures, right? It's a restorative failure. So the longer you put the tooth in a temporary restoration, in CAVIT, in RM, in GIC, that tooth is going to fracture, right? And yes, you can take the tooth out of occlusion, but if you put a nut underneath that tooth and go crunch, it's going to break, right? So the restorative should happen after the root canal as soon as possible, right? To prevent it from fracturing. And that's the reason why I do single visit endos, because of that restorative aspect of it. Now, there are some people who do it in 2 visits, and that's perfectly fine, right? And I think a lot of people, I think some of the concepts, they use the calcium hydroxide to disinfect the root canal, help disinfect the root canal, and also from a patient standpoint, also see whether the symptoms reduce. So, for example, a lot of people with cracked teeth, they would do the root canal, put some calcium hydroxide, see whether the pain goes away, and then go from there, which is perfectly valid. That's, and sometimes I actually do that as well. But for me, especially with cracked teeth, right, the tooth is due, in my opinion, I'm not a specialist, but in my personal opinion, if you put if you put calcium hydroxide, you put a temporary filling in, and then the tooth is still painful, right? Well, it's one of two things. Either you haven't achieved all the aspects of root canal that you want to achieve, maybe there's an extra canal, something like that, or the tooth is not restorable because of the crack, right? So, and also people are saying oh, you put calcium hydroxide for 6 months, all right, and see how it goes. Well, during that 6 months, the tooth could fracture. So it's that, and that would be a shame if it does. So that's the reason why if I do calcium hydroxide, it's usually about 2 to 4 weeks, and then I'll finish up the case, because I want to make sure that I put a really strong permanent restoration on top of my root canal as soon as possible, right? Because I don't want that tooth to fracture.
The scary bit, I think, for me about the concept of single visit endos, I think for me, it was that thing of a patient comes in pain, I've instrumented and placed calcium hydroxide. Usually I leave it for 4 weeks, but I'm not game to obturate until I know that that tooth is asymptomatic. I think that's just how I've gone about it. I still feel like endo still feels like voodoo magic sometimes. So I'm oh, it worked. Okay, cool. Now we'll obturate. And usually I do my crown prep at my obturation appointment. So usually it's obturate, crown prep, and then cement. So if ideally that, and then that can take those. Instrumentation's usually my long one, where it's like I'll try to do it, and then if not, sometimes I need a second visit to continue doing it. But I guess for you, what gives you the confidence of being able to instrument and obturate at the same visit and be confident that they're going to be out of pain?
Well, endo is actually quite, like, the prognosis for endodontic teeth, actually, it's quite good. Like, you think about it, a tooth with irreversible pulpitis that has a success rate, a root canal on that has a success rate of 90%, right? And one with periapical radiolucency, it's 80%. It's quite high, right? So for me, if I've already achieved all the principles, all the, I guess, objectives of endodontics, so basically clean shaped canal, disinfection, and all that, it just shouldn't be a reason why the tooth is still symptomatic.
Sure.
All right. And we've actually seen that, right?
Mm-hmm.
And I feel that aspect of it, that theoretical aspect of it, gives me that confidence, right? So, as I said, if the patient's is still symptomatic, then obviously, don't obturate it. But my point is, if you've already achieved, if let's say you've done the instrumentation and then they're still in pain, there must be something else going on. All right. So then the question now is, you have to find out what wrong is it, right? And I actually have a case coming up, stay tuned, where I did do a single visit root canal on a patient with quite a large periapical radiolucency, single visit, bioceramics, like warm vertical obturation with bioceramic, everything works well, had a new cute lateral puff, right? Because it was a lateral canal, right? And 3 months later, she had a sinus tract, right? So it did not work. And the reason why is because the lateral canal, just because you seal it doesn't mean it's clean, right? So that meant I didn't disinfect that tooth properly enough. So I had to retreat it. I increased the apical size. I did dress it for 4 weeks just to help. And also I tried to clean up the lateral canal as much as possible, right? And those aspects are the rare cases that do happen. And I obviously have to fix it. But in most cases, it is predictable. If you achieve everything that you set up, the goals of endodontics, and like disinfection, shape, everything goes well and according to plan, it shouldn't cause any pain afterwards, right? And as I said, for the number one form of failure is the restorative failure. So, the patients are paying big money for a root canal. It's not cheap, right? And you tell them after a root canal, if the tooth fractures, then it's like, it's not great, right? So we want to protect that tooth, and that longevity comes from the restorative, actually.
Yeah.
And we know this because we've seen a lot of people focus on the obturation, right? Because of Instagram, right, and all that. Like, you want to see those lovely white lines and those puffs here and there, and those like aesthetic obturations. But ultimately, disinfection is the most important, right? And we've seen cases where you have like terrible obturations, but the tooth has lasted for decades. And that's because the tooth was probably disinfected adequately, but the obturation just wasn't great, but it's still functional and asymptomatic.
So when it comes to disinfection, if you were to give one single tip, and we're talking about the success of an endo is primarily dependent on how well you cleaned and disinfected it, is that related to how much we irrigate it, how much you're filing it? Like, if you were to, I don't know if this is too broad of a question, but if you were to give like one thing that you feel like we should focus on or maybe gets overlooked, what do you think it would be?
That's a very interesting question because, well, first of all, it's impossible to achieve sterility inside the root canal, right? Because we know we cannot fully disinfect the root canal, regardless of whether you use an endoactivator to activate your irrigants or an ultrasonic or lasers. It's impossible. So our goal is to reduce the bacterial load inside of the root canal system to a point where it promotes periapical healing if there's a periapical inflammatory lesion, or to get the patient out of pain, right? And so to maintain that tooth to be asymptomatic and functional, right? So that's the goal of that. But then the question is, at what point do we know, okay, I've done enough? And the answer to the question, it's impossible, right? You don't know. But as a rough guide, for me, I personally use 5 ml syringes, right, for my hypo. But if let's say most people are using the 3 mil one, so I'll use at least a minimum of 12 mils of syringes of hypo, right? And then I use one syringe of EDTA as well. So that's like a little rule book for me. Is it going to improve the success rate? Is it going to disinfect all your canals? There's no, like, it's impossible to tell, right? But that's roughly a guide for me. And I think that aspect of it is like, that's going to give, that should be enough for most cases. And obviously there's no such thing as not insufficient. Like, you can always irrigate again if you don't feel like it's not clean enough, right? So you're just like, oh, I don't think I've done enough. Okay, just do another syringe then, just another syringe of hypo.
Yes.
But personally, that's my rule book. Just 12 mils of hypo and 3 mils of EDTA. And also time as well. So that's volume and time. So if you like, if your endos are like not 5 minutes, but like 20 minutes of irrigation, right? That's probably not enough. So you need enough time for the hypo to like dissolve and do its lovely thing. So yeah, honestly, part of it is time, and that comes with the appointment anyways, right? So if your root canal is long enough, then that's already giving you that time for the hypo to do its thing. If you want to activate your irrigant as well to try and improve the disinfection, you can. It doesn't improve outcome, but there's no harm doing it either. So that's what I do. Makes you feel better. I know that there's a ton of studies that show that it doesn't improve outcome and all that, which is true. It doesn't improve outcome, but it doesn't decrease outcome either. So, and it helps me sleep at night. So I just do it.
I guess with that. Yeah, 100%. I had that the other day where I had one particular case. I can't remember what it was. I think one of our new grads was asking us. I'm like, I don't know if it will help or not, but I'm going to agitate it just because it makes me feel better. And I've tried.
Yeah.
I've just tried my best.
Exactly. That's literally, I do it all the time. It's like, I was like, just do it anyways. Especially if there's a lateral canal, I was like, well, the tooth's not going to die if I don't do it. So, and it's just not going to, there's no change in outcome whether I do it or don't do it. So I just do it for my own sanity.
One thing I did start doing though is, I guess, in terms of ensuring enough duration of it, is at the end, like just before obturating, I'll usually just leave it in there, and then, because I know that by the time you're obturating, like, okay, you're done with all your endo equipment, right? And so that's the time that I just leave the hypo in there, and then my DA and I pretty much just do our whole pack down. Like, we clean everything up, I chuck things out, I take apart my x-ray holders, I write up my notes, and that's what, like a good 5 minutes minimum. And then when everything's all tidied up, like, okay, let's go back and like finish this off. Because I think that's also the same thing for like other procedures, is that we're terrible at just waiting and just sitting there and watching. So you just have to, if you want to leave it there, you literally have to go find other things to preoccupy yourself with. Go clean up, go write your notes, go have a coffee, and then come back to it.
So yeah, if let's say, like in those cases where there's quite a large periapical radiolucency, or if let's say I know there are lateral canals, anything like that, I usually use 1% from what's the brand of hypo, 1% hypochlorite, right? And then on my final rinks, I switched up to 4% hypocell, which is a special type of hypo that has a surfactant in it that helps dissolve tissue a little bit more. So what I do is I just use that as my rinks, right? And then I do my cone fitting whilst the hypo is already in there. So that's my 5 minutes. So I save a bit of time because I'm already doing the cone fitting. And as I am putting the cone fitting in, I like check and tug back and all that. There. That's me activating the irrigant as well. So I do that. I kind of check it and I take my master cone and all that. By the time that happens, it's 5 minutes, right? Then I do my EDTA, then I activate, right? And then I do my final rinks of like whatever's left in that syringe, right? In that 4% hypocell syringe. I just use that, finish it up until there's no more, and then I'll just suck it all up, and then I'll dry canal and then obturate. So that's how I kind of save time. So instead of me like just waiting around packing, or just waiting for the hypo to do its thing, that's how I kind of be a little bit more efficient, just doing my master cone whilst it's in the canal. Yeah. So I mean, I do know a couple of an endodontist that actually does what you do actually, and he puts the hypo inside and he just lets it sit there, and he goes off and does like consults And he like, and he comes back. It's like, okay, we're ready now. And he like he irrigates and he obturates.
We just let it marinate, I think is what I've heard an endo call it. Just
let it marinate. Have a jacuzzi. Yeah, that's literally why I tell my patient, because they feel the endo activator vibrating, and it has like a really buzzing now, like sound like that.
You're in the jacuzzi.
Yeah, just like, just don't mind me. I'm just putting your canal in the jacuzzi, and then they usually chuckle. I just activate.
Oh, that's really awesome. I think there was so much just like goodness and just tips and tricks in just that little segment there. Dentistry is stressful enough as it is. Nothing is more daunting than the prospect of a patient complaint at any point in your career, but especially as a new grad. However, thanks to Dental Protection Limited, I know I can sleep a little easier. If you signed up as a student, you'll be automatically covered for your first 18 months of practice for free. Now, for those in the same boat as me, it is now time for us to renew our indemnity insurance before June 30. Now, I've been working alongside DPL for years now, since my student days, and they have always been such huge supporters of everything I do, including the Graduate Dentist podcast. And so I know when push comes to shove and the time calls for it, I can trust DPL to have my back and to be in my corner. With a team of experienced dental-legal consultants and an abundance of resources, including webinars, their own podcasts, blog posts, and magazines, you know DPL's got you covered. Thank you, DPL, for always looking after me and for supporting the Graduate Dentist podcast. Another question that I wanted to ask, and this was something that kind of blew my mind. I think it's one of the very earliest posts that you shared on our Discord page. But we started this conversation about single visit endos. But before, when you were talking about when we're having that conversation with patients about, do you want to save your tooth, or do you want to give it to the tooth fairy? Or I can buy you a bit of time, right?
Yeah.
Let's talk about that, because essentially that means extirpating the tooth, right?
Yeah.
But I think you have your thoughts on how we go about extirpating depending on your diagnosis. Is that correct?
Yes, that's true. So it depends on the diagnosis or the endodontic status of the tooth. So a lot of people think that, let's say you have a tooth with irreversible pulpitis, right? And the tooth is like, usually those are like, they hurt a lot, right?
Yeah.
So, right, they look painful. So you go in there, and a lot of people think, okay, I got to take the tooth, like as much tissue out of this tooth as much as possible. I got to put my files in there, and I do everything. That is actually not true, right? So the way, if you look at it from a histological point of view, when tooth or when the pulp undergoes pulpitis, it kind of goes more coronally down, like from coronal apically, right? So it's most inflamed in the coronal portions of the pulp. So if you have a tooth that has irreversible pulpitis, and especially if you don't have enough time, right, all you need to do is just do a full coronal pulpotomy. So just remove the top part of the pulp in the pulp chamber. You can leave the pulp, like the radicular pulp, behind, like at orifice level, and then that's it, done. That's more than sufficient to take the patient out of pain.
What are you using to remove it?
Just high-speed burr, and just just
with water.
Yeah, with water. Yeah, definitely with water. Yeah.
That's what I'm saying. I'm like, how are we doing? It's not like a gingivectomy, right?
No. Actually, it's similar. Actually, so you take a diamond burr, you go in, and you obviously you open up the pulp chamber roof, right? You see the blood coming out, usually hyperemic, right? And you just go and open up a little bit more, and you just, whilst using a burr, sometimes I can actually feel, like by feel, the base of the pulp chamber floor. And you just don't go all the way down there because you don't want to perforate, right? So you just feel it, and you just kind of buzz it around, like around your access a little bit, expand it, and usually that, like the water and everything, just rinses it all out, right, and removes the pulp at the same time. Has to be a diamond burr as well, because it cuts pulp as opposed to like rips it out. So it cuts pulp very cleanly.
So no slow speeds, because that would just rip it out, right?
Yeah, I mean, I actually, to be honest, I don't really use slow speed a lot because I don't like how it shakes the patient's head, right? So I usually just use diamond. It goes, gets it all over me. It buzzes around, and then I use a syringe, hypo, just give it a good clean, just to disinfect it.
Does it keep bleeding, or does it stop bleeding?
Most of the time, it stops bleeding, like, or it oozes a little bit, which is fine, right? Because most of the pulp is gone. If it's still oozing a lot more, then I might take the Dynabar a little bit more deeper just to clean it out. And then this is when I get a little bit nervous. So I went to a talk with Prof. Peters. So he's very into vital pulp over at Peters, right? So he's very into vital pulp therapy, and then the literature is already clear that medicaments don't actually. There's no significance between in terms of post-op pain if you put a medicament or not. So he's saying just put a cotton pellet in and then temporize. You don't even put any medicament in. So that aspect is sufficient enough to take the patient out of pain. I have done it once and it has worked, right? But I don't know. I still feel a bit nervous to do that. I still feel a bit nervous doing that as well. So I do put a little bit of odonto paste inside the canal. Right, he's probably his ears
in the canal or just in the pulp chamber area.
Oh, sorry, yeah, so in
just
the pulp chamber.
Yeah.
So that I literally get like the odonto paste in the pad, and then I scoop up using flat plastic and kind of smear it inside the canal, and then use a cotton pellet to kind of stuff it in. His ears are going to bleed if he listens to me. Right? Yeah. And then I usually, for vital cases, always use IRM. Because IRM, or I think some people use calcinol, that's the name of it. Zinc oxide eugenol-based temporary filling. And the reason why I use that is because it has what we call obtundant effect. So because of the eugenol, right? So it calms the pulp down. So I use that. And in most cases, that does it all. It's very predictably.
Is that all you use to seal your access? Because we don't have IRM at our clinic, and so
then you can use like Cabot or GIC or Fuji or whatever you want to use. But I like IRM because it has that obtundant effect. Right?
Sure.
Yeah. Because I'm already tackling it from all fronts, right? I'm already removing the corona pulp, and then I'm putting some odonto paste to cover it up, and then I'm putting IRM. So like that
everything.
For me, everything is on that too. So
yes.
In most cases, right, that is more than sufficient to take the patient out of pain. And there's actually literature to back that.
Irreversible pulpitis case.
Yes, irreversible pulpitis case, yes. And that's already been shown in the literature, right? And that's the reason why vital pulp therapy works.
Sure.
Because it's by that same concept, right?
Where it's not actually, I'm trying to think of the proper terms, but it's not actually infected, right?
Yeah, well, you're correct, because you're removing the inflamed pulp coronally, and you're leaving behind the radicular pulp,
which is vital and healthy.
Correct, yeah. So that's the way vital pulp therapy works, yeah. Now, if you have a necrotic tooth with, let's say, periapical radiolucency or chronic apical abscess, then that's different, right? You can't just do a corona pulp on it. So you have to go in there, like get the files in there and try to disinfect in there. And the best way to do it is to kind of shape the canals up to at least a size 25. All right. I think that's the reason for that is to allow the irritant to go all the way down as much to the canal, right? But in reality, especially if you have 30 minutes on the clock of a very calcified molar, it's very hard to do that in that short period of time. So for me personally, I just take a size 10, 15, just jiggle up inside the canal, just give it a little jiggle, right? And I disinfect it as much as I can. And then I put odonto paste or calcium hydroxide, whatever my patient, or whatever my nurse can get out as fast as possible, right? And then I put cotton pellet, IRM, or GIC over the top. And in most cases, that will buy, because the purpose of this is to just buy the patient some time, because the patient needs to come back for the root canal, right? So so the patient usually that buys them a couple of days or a couple of weeks, and then the patient comes back and we start the root canal then, right? So that's how I do it. If obviously there's pus coming out, I think there was a recent case in Discord.
On the Discord, oh my goodness.
I've encountered that before, and it's really scary. But it's also very satisfying to see the pus come out as well.
Can you give our audience just a recap of what that case was?
Yes. Yeah, so I think it was a case on 3-3. Lots, like she opened up the canal and then there was pus coming out of the tooth endlessly, right? And I think the patient was feeling sick, fever, like vomiting. And when that occurs, that's when you use antibiotics, right? That's when you have to use antibiotics for this case, because it means the infection has spread and it's called systemic symptoms. So for that case, unfortunately, like if the pus is still coming out, you got to just suck it all up, right? Just keep irrigating, keep sucking it all up. And then, as I said, I in the post, I use like a surgical suction, and then I attach like the flowable composite tip onto my surgical suction.
That's crazy.
Yeah, and
yeah.
then I put it inside, and then just let it drain out from inside. In most cases, it eventually dries up, but if you have something like that, yeah, it's going to take a while for it to keep on irrigating. And then calcium hydroxide, and then put a covering over the top of it, like a temporary filling. A lot of people, there are some people that think that you should open up leave it open to let it to drain. Like there's no really evidence or sufficient evidence that will support that will reduce post-op pain. And also, if you think about it, you don't want to be introducing more bacteria from your oral environment into the canal by leaving it open, right? Because that can change the environment, that can also cause more problems. So usually, in most cases, I would just irrigate and just let it drain, right? If there's an extra oral like swelling, I'll like pop that sucker with a scalpel, which I love doing. But yeah, it is hard in those situations. And then also high dose antibiotics like augmentin. That's what I would do, and that will hopefully get the patient out of pain. If let's say she's still out of pain, I might have to open up and irrigate again. It is hard. It is very scary as well, and it has encountered. I have had a case like that. But like endodontitis is predictable, right? So it's like if you keep draining and all that, yeah, you trust the process, right? So in those cases, you open up the tooth a little bit more. Let's say like if you go into that tooth and you shape it to a 25, right? Then maybe shape it more like use a rotary to shape it to like an F3 pro taper goal, or maybe a wave one goal primary, or maybe a medium to try to open it up, get more irrigant in, let it more drain out, or that pus come out. So eventually it does drain and it does get better. And I think the patient was out of pain at the end of it, right?
Yeah, they were. Yeah. It just took a bit of time. I think once they finished the antibiotics, they were like, it was resolved. I didn't think I would enjoy listening to you talk about endo for over an hour as much as I have. It actually was really interesting, and I was very fascinated. And I think also what was really enjoyable is just seeing how passionate you are about it. And I think in the eyes of our graduate dentist audience, you're already an endo. But I know that right now you are in your process of acquiring your further training and doing all the necessary things so that you have a good chance at getting into postgrad studies.
I've done whatever I can, to be honest. I hope I get it. I don't know what more I can do, to be honest.
Well, we have our fingers and our toes and everything crossed for you. And hopefully you get in, but if not now, it'll happen. I believe that if you've got the passion and the drive for it.
Yeah, if there's any prof listening to this podcast, please let me in. like, please let me in. Like
I don't know what he will do if he doesn't get into endo.
I know, like I waited 3 years for this moment.
He might shrivel up and become necrotic.
Yeah. You're not wrong.
Oh, Zi, thank you so much for this conversation. I want to ask you just one final question to end our podcast. And you would know, we ask this to all our guests and all our listeners. We have so many conversations with people day in, day out. You're obviously a big part of our Discord community, and you speak to a lot of specialists as well on Instagram. You really put yourself out there. You've also been doing a lot of traveling recently. But I guess amidst all these travels and all these interactions that you have had with people, I imagine you would have had quite a number of conversations, or maybe even conversations you had earlier on. Has there been one that's really stuck with you, that's resonated, that has a special place in the back of your head there, that you think would be good and would be beneficial to share with our graduate dentist audience? I hope I'm not putting you on the spot with this.
Ooh. I think I remember this chat with Mehdi, right? He's such a great guy, honestly. I like how the way he explains that, how he's done every single like especially has done every single mishap in endo, and that reassurance that even they've done it all, so they understand from our perspective of what it's like. I think that reassurance kind of allowed me to be more comfortable in making mistakes and learning from it, right? because we're under the impression, like, I feel like as general dentists, being a general dentist is really hard, right? It's actually really hard because not only do we are the first line of defense before a specialist, right? So we have to talk about, like, we have to deal with the patient first, like with communication, treatment planning, and then we have to talk about the crown afterwards. Whereas the specialist just obviously does the root canal and does that aspect, but he doesn't have to, like, he or she doesn't have to worry about the restorative afterwards, right? That's a general dentist's job afterwards, right? So I feel like as general dentists, like, life is hard, and like when we have to do that on top of dealing with managing like the tooth itself, that can be quite hard. So having that, so knowing that he because they used to be general dentists as well, right? Having that reassurance that, perspective as well, and that reassurance that, okay, yeah, it's hard. This is how I manage it. It happens. It's okay. And if anything goes wrong, I'm there for you. That was really nice. I would say my last final advice for grads is, I felt like endo is taught in dental school like as a protocol, right? Which it is. It's like you have a protocol. So, but each dental school would teach students in a different way, like depending on the file system or the supervisor, how they do root canals, right? Endo is taught as a protocol. Like you have to use size 10, 15, 20, the kind of thing, and then use whatever system you have here. But instead of memorizing the protocol and then approaching every case like that, I would say understand the thought behind it, because there's so many different file systems out there, right? And there's so many ways you can do a root canal. There's so many like continuous rotation, reciprocating files, and all that. So you have to have some openness when you're doing a root canal in private practice, right? So I would say, don't approach, when you learn endodontics in university, have an open mind that, there are other ways to do root canal as well. And understanding the principle and the thought process behind the reason why you're taught this way will help you deal with root canals in private practice, right? So, because I see a lot of fresh grads, they learn the protocol from uni and they go into private practice and they use a totally different file system, and it's like, oh, but I was taught this way. But then he's like, no, I mean, it's nothing's changed, to be honest. It's just you're using different equipment. You just need to be a little bit more open and be more flexible with like readapting what you've learned in uni, the concept and principles, to use different equipment. You can use any file system on any root canal, but having that openness to like adapt to situation, be open with receiving new knowledge, not being like, okay, this is the way I taught, will help you also troubleshoot whenever you deal with situations. Like when it's like something doesn't go right or something's not working, it's like, okay, how am I going to fix this problem? Because a lot of people think like endo is done in a certain way, and then when things go wrong, it's like, oh no, like I wasn't taught this. I can't do it. I can't do this anymore. But if you have that openness and troubleshoot and problem solve, that will help you deal with like tricky situations. And it's not just for endo, by the way. It's the same with all aspects of dentistry. Having that openness to learn more even after you graduate, right? So you don't learn everything in dental school. You learn the fundamentals in dental school. It's true, right? You learn the fundamentals, the fundamental basics in dental school. But then when you go into private practice, it could be the same thing, but just adapted differently, or it could be something that's completely new, right? And you have to have that flexibility to learn. And that's the great thing about the Discord group, right? Is we can bounce off ideas in a safe space, right? Where you will get different perceptions for people all over the world, right? Of how to deal with a situation, right? Or how to deal with this case. So having that openness to learn is what's really important. And then the last point I wanted to make is, don't be afraid of making mistakes, because we all make mistakes. You will encounter a situation in endo where the mistakes may lead to tooth being lost, but ultimately it's just a tooth, right? Right? It's not the patient's life.
Aren't you glad you didn't do neurosurgery? It's just the brain, really.
It's just the brain, right? Like, but you know what I mean, right? It's like it's like mistakes do happen. As long as we learn from it, that's the main thing, right? And I learned way more from my mistakes than my successes, right? Because if you do a sex and you feel good about yourself, then you're like, oh yes, I did everything right, you know. Whereas if you make a mistake, it's like you learn from it, like, oh, I should have done this, I should have done that better, I shouldn't have done this, and that's way more important. Yeah.
I
So,
love that.
I think there was, who was the one that said falling forwards? Was it you?
Lingaya.
Ah, yes.
Yeah.
So yeah, always falling forwards. Right?
Mm-hmm.
Yeah.
I love that. That's awesome. What a wholesome podcast, eh? I really, really enjoyed it. And I'm sure our listeners will have as well. So thank you for your time. Thank you for sharing all this knowledge and this excitement and this passion for Endo and making it seem a little less scary and a little less, dull and boring and scary and daunting.
I know it's a great thing about Endo as well. It's very therapeutic, isn't it?
Yeah.
Yeah, you can just listen to some music in the background while you're doing Endo.
You listen to classical music, don't you?
No, well, not actually. I have my friend actually. I'm using his playlist right now. He plays like this indie type music, and it's quite calming.
Yeah.
So I used to listen to that in the background, and it's like, it's nice. You know?
It reminds me of C. I think C3 shared a reel once. We made a reel where he's just like, the kind of music that gets played in different dentists' offices. And he's like, you've got the max fax oral surgeons who are listening to like hardcore metal music. You have the restorative dentists that are listening to like EDM. And then you have the endodontists that are doing
just for release in the background.
Yeah, for release.
Honestly, the reason why I don't play classical music is my nurse said, like, he's going to fall asleep. Yeah, so I was like, we play some indie music, so it's like calming, but it still keeps you awake, kind of thing. So yeah, that's nice.
No, so good. Thank you again for joining
us. No problem. And obviously, if anyone has any questions, they can always DM in my Instagram or also DM on Discord. Zi En Dental, that's right.
And thank you guys so much for tuning in to another episode of the Graduate Dentist Podcast. I really hope you've taken something valuable away from this episode and that you feel heard, you feel seen, inspired, and optimistic about our journey as graduate dentists. As I always say, we're in it together, so let's spread the word, let's share the love, send this to your friends, your colleagues, and those who are on a similar path who you feel may benefit from being part of the community. I'd love to hear your thoughts, so send me a message, and we'll see you again in 2 weeks' time for another episode.